Okay, thanks everybody. I faced the same dilemmas and difficulties as the last speaker in deciding what it was most useful for me to talk to you about today, and our health integration team also faced the same dilemmas and difficulties about our acronym, since we're about sexual health as opposed to self-harm. But anyway, we solved those latter dilemmas by calling ourselves SHIPP, rather than the alternative, which stands for Sexual Health Improvement for Populations and Patients. And I'm the director of SHIPP. I'm a GP in Hartcliffe. I also work at the School of Social and Community Medicine. So, right, okay, that doesn't go forward. Right, okay. Right, no.
Gone too far now, is that right?
Yeah, that's it, yeah.
Yep.
So just press those,
Yeah,
right, okay. So, I mean, I'll start by saying something quite general, and then I'll say something a little bit more specific that I think exemplifies probably some of the issues most of us who are involved in HITs have faced. So SHIPPS is a health integration team. It's a partnership between different people from the different organisations that are listed on that slide, and also patients who have got an interest in sexual health and a belief and an ambition around improving sexual health through evidence-based interventions, and those might be interventions at the population level, or they may be interventions at the individual level. Oops, wrong way. So, I mean, it was interesting. David this morning was talking about how do the HITs align themselves with local priorities. Well, the way we try and do that is that we work with the existing assessments and prioritisations of need that exist locally, primarily the Joint Strategic Needs Assessment, and then based on the sexual health priorities identified in the Joint Strategic Needs Assessment, we advise the people who commission sexual health services. So they may be in clinical commissioning groups, they may be in the local authority, or they may be in NHS England, around commissioning evidence-based care that meets these needs cost effectively and provides value for money. And in engaging in that process, we identify where there are evidence gaps, and we try to facilitate research to fill those gaps, broadly speaking. So here are some examples of projects, of primary research projects that we've been undertaking over the past year. This is not an exhaustive list. We have a whole programme of work around PPI that Jane Myrick, who is sitting at the back of the room, leads with Deborah Gray, that isn't listed on this slide. But we have projects around strengthening chlamydia screening. We had a project looking at the prevalence of Trichomonas vaginalis in the community. There is a whole programme of research led by Jean Fader and involving Jane Bailey, who's also in the room, around recognising and responding to intimate partner violence. There's a more nascent programme of research around increasing earlier diagnosis of HIV that's led by Mark Gompels and Margaret May. We have recently been working with Bristol City Council around refreshing the sexual health chapter of the Joint Strategic Needs Assessment, and one of the ways that we've been doing that is through providing them with local population-based data on sexual health need from the Avon longitudinal study of parents and children. We have projects around improving patient pathways in specialist sexual health clinics involving point-of-care tests that's led by Paddy Horner, and we also have several projects undertaken in collaboration with the MRC Farr Institute around using routine data in the evaluation of sexual health interventions. I'm now going to talk more specifically about one small project that we've been undertaking over the past year, because I think our experience in this project exemplifies some general issues that HITs face. This project is called Impact PC. It's about improving the management of patients with chlamydia and gonorrhea diagnosed in primary care. So the background is that if we think about chlamydia, it's important, it's common, it's got a substantial amount of morbidity associated with it that is potentially preventable through effective treatment and partner notification, and that's why we have a national chlamydia screening programme, which is expensive and takes up about 10 to 15% of sexual health spend locally. And within this programme, about half chlamydia tests undertaken are undertaken in individuals attending primary care for reasons completely unrelated to their sexual health, and not a insubstantial proportion of these tests are positive, mainly for chlamydia, some for gonorrhea, and primary care is not particularly well set up to deal with these positive tests when they arise effectively, which is a shame, because if they are dealt with in a timely and appropriate manner, and if partner notification is undertaken, then this is effective at reducing the morbidity that is otherwise associated with chlamydia. And we recently, well, over a year ago now, not that recently, surveyed local GPs about what they perceived their needs were around sexual health, and one of the things they told us was that they would value help to do this sort of thing better. So out of that came this project, which is a feasibility trial evaluating the feasibility and acceptability of a centralised, office-based, nurse-led treatment and partner notification service for chlamydia and gonorrhea tests diagnosed in primary care, where the result of the test is notified directly to this office by the Public Health England lab that undertakes the test, with a contact telephone number for the patient. So intervention practices have the option of managing their patients in this way. Control practices do whatever they would normally do. And we were successful about a year ago in obtaining support from Clark West and the Health Protection Research Unit that's based at the School of Social and Community Medicine. In the spring of last year, we got ethical approval in the autumn of last year. Following that, after a somewhat tortuous process, we successfully got NIHR portfolio adoption, which allows us to use the clinical research networks to recruit practices and allows us to provide practices with service support costs. And we started enrolling patients in April this year, and the study will run till the end of September. And we hope that it will form the basis of a bigger definitive trial to see if this thing works. So the issues that I think this study has highlighted that we could maybe discuss later on are that primary research within the HIT model, research that is not externally funded anyway, still takes as long as it normally takes, and most people agree that it takes too long in terms of its ability to inform practice. And the HIT-friendly funding streams like the Clark, like the Health Protection Research Unit, are great, and it's great that these funding streams are available and that HITs can apply for support from them, but they're really most suited to supporting secondary research, because they don't provide money to undertake projects with. They provide expertise in the form of people, and this expertise is mainly in data analysis and evidence synthesis. Really, they have a limited ability to support field work other than relatively small-scale qualitative field work, which is obviously important, but some field work is not of that nature. And there is still confusion over portfolio eligibility, particularly for Clark-funded studies, which has major implications in terms of their ability to recruit patients and research sites using the clinical research networks, and their ability to provide the research sites with service support costs, which obviously has major implications for the viability of the research projects. Okay, so try to end on some relatively positive conclusions. I think, by a number of metrics, HITs are a success, and they are supporting evidence-based commissioning in practice. Obviously, we need to be ambitious, but the ambitions that we expressed in the 5-year plans that David was alluding to earlier in his presentation, some of them were perhaps a little bit unrealistic, unless they related to projects that essentially were already funded and were going to happen anyway, whether or not HITs as a concept existed. And in view of this, HITs are evolving, and I'm sure they'll continue to evolve, and we'll continue to meet and talk about them. Thanks very much.